has a huge amount of experience with working with young people, because for about 20 years he was the chief executive of Red Thread, which is a youth work charity. And John is going to share some of his experiences about what he learned through that, as well as some of his visions in terms of supporting young people. And he may well touch on some of the work he's done with Dave. Dave, unfortunately, can't join us for family reasons, but may well touch on something about the HEEADSSS app as well. John, over to you.
Brilliant. Thanks so much for having me, Sanjay. And I'll share a few slides. Yeah, I'll speak briefly on behalf of David James, and I know that although he can't be with us today, undoubtedly you might want to join his another conference that he'll be running, the Royal College of Emergency Medicine's Forgotten Tribe conference, all about young people, in a few weeks' time, where you can then catch up much more clearly and eloquently than me sharing some ideas myself. Let me share some slides and share the right page. There we go. Okay, I think can you see that? There we go. So yeah, my name John Poyton. Sanjay's introduced me. I will talk about young people, but we'll also touch on David's area of expertise around the HEEADSSS app that he developed. So as Sanjay said, I set up a charity called Red Thread, and in that sense, we'll talk a little bit about some of those young people that we've referenced, different presenters have referenced, who are perhaps labelled as hard to reach, when actually we need to flip that on its head and recognise that sometimes it's the systems and the services that we design as adults that are hard to reach. And Holly, I thought your presentation just then sort of really helped touch on bringing out sort of young people's perspectives and the lens through which young people look, and the way that we see things differently. I also am the co-founder of a primary care specialist adolescent hub or program called the Well Centre, which we set up 12 years ago. And we'll talk a little bit about, again, the tool that we use to help walk the young people through a conversation that is supportive, but also helps us to helpfully and supportively open Pandora's box. Because this is where I started my journey. My background is not in health. I'm a youth worker and worked in social care for many years, until 20 years ago when I came in and founded Red Thread's work. The conversations I had back then and through the last 20 plus years was with doctors and nurses in a really busy clinical environment who were really concerned that they didn't want to open Pandora's box. I'm sure you're all super familiar with the Greek myths, and there's lots of different versions of it, but opening Pandora's box, asking questions that you don't feel you have the answer to, particularly in a busy emergency department or in a short 10-minute appointment in primary care, or whatever wherever it is you're coming from. If you don't have the answer, then you're creating more of a problem. And this was the conversation that I would have time and time again. And we recognized that youth work and having an allied health professional who was a trusted colleague, who could then walk alongside that young person and support them, was key. And that was Red Thread's journey in setting up what turned out to be at King's College Hospital, the first hospital-based violence intervention program, leveraging the teachable moment when young people were perhaps stabbed or injured, exploited, and ended up in the emergency department. It was really key to leverage that moment, but not just obviously to treat them, to stop them bleeding, to get them into surgery if necessary, but to ensure that conversation and that support continued when they were discharged back into the community where they were perhaps back at risk. And again, similarly, the Well Centre model is all about having a workforce of allied health professionals, youth workers, or we call them in the Well Centre, health and wellbeing practitioners, who can work beyond that short primary care GP's appointment and support those young people, but work as that multidisciplinary team. And so hopefully some of the things I'll share will touch on a number of the things that previous speakers, brilliant speakers that we've had this morning have spoken about. Simon obviously talked about that difficulty of finding the right voluntary sector or charity partner when you're looking at the broad gamut of issues that children and young people are dealing with. Obviously, we're slightly narrowing it down when we start to look at adolescence, but at the same time, that's still pretty broad when we're now recognizing that goes from, you know, sort of 11 or maybe the early teen years all the way through really to 25. But it starts to make it slightly easier. And we'll touch on that as well. So I think we often think about early intervention, upstream prevention. What can we be doing either in the community with either young people's health or if, again, blood pressure checks and other sort of interventions in the community? What can we be doing to capture need as early as possible? Going through primary care, we're going through to the local district general or local emergency unit, and then we're thinking about major trauma centres. Again, I'm generally talking about this from a high risk, vulnerable adolescent cohort, and for the last 20 years thinking about knife crime gangs, county lines, as Holly referenced, and thinking about how do we start to meet those young people in the point of need, and not the point when we tell them they've got a need, when they arrive in situ in an ambulance with a knife, either still in or having been stabbed. They're probably aware that there's a need, but again, they need a supportive conversation that helps them recognize this is not just about stitching up and sending you home. This is a really clear opportunity to have a conversation that doesn't just stop at the door of the hospital, that continues out into the community. So we often think about it as very linear, that people end up moving through and getting to crisis point. But what do we do then? And at the moment, if we are thinking about that really high risk, vulnerable cohort who maybe identify as a gang member or not, but have been victimized and ended up in your emergency department or on the ward of your major trauma unit, what happens when they do go back home? If you don't have a red thread, or there's lots of other charities and organizations delivering hospital-based violence intervention programs now, what happens? Well, the emergency department probably sends through a discharge summary letter to the GP. Does the young person then re-engage? What are we doing to really properly integrate the health system for these high-risk young people? Because I hope you can see all my slides. My slides seem to have gone slightly, but you should be able to see the whole bell curve there with obviously we're talking about kids right at that high-risk end of the bell curve. What are we doing? We've got to think about how do we properly integrate the whole of the health system. And it's why I'm really delighted to be part of this conversation with Healthier Together today, to think about exciting opportunities in the future around AI and how do we start to screen, how do we start to connect systems, how do we remove perhaps some of the boring jobs so that we can focus on the young people in front of us. But also, if we're thinking about that child or that young person at that really critical crisis moment in your emergency department, up on your ward, sitting in front of you in your surgery, we've got to also start to think about the ripples in the pond, the teachable moments for the wider community. That child, if we just use those sort of ripples in the pond that I've borrowed from Carleen Furman's brilliant contextual safeguarding framework, we're thinking about every child or young person within their family dynamic, their peer, their siblings, their parents. And what are we doing to support them? What are we doing to support their peer group, their friendship group? Again, those at school, or perhaps they're not in school. What are we doing to support the wider school community and the wider neighbourhood? We've got to think about those things, and we've got to do better for young people in thinking not about the health system as linear and sort of escalating, but how do we support the biopsychosocial needs of adolescents and ensure that once they've been in crisis, when they come back into the community, back at home, on their doorstep, how do we ensure that they re-engage with primary care? Because I think it's fair to say that in general, young people when they are becoming responsible, when they are in that vulnerable transition between childhood and adulthood, they're not encouraged to re-engage with the health system in their own right. And I think there's some really exciting work to be done there. And I'm not here to say that I've got all of the answers, but I'm delighted to be a part of the conversation and be delighted to have conversations with you after this conference to think about how do we do better for young people. Because the system that young people have to navigate is incredibly complex. And just a doodle from a little while ago, just thinking about young people living in the green environment of their residential home, health system as red, the criminal justice system as blue, social care in purple. You get the idea. This is incredibly complex. And again, too often, the system, us as the adults, label young people and patients as hard to reach, when actually the system itself is incredibly hard to reach. The beauty of the health system, the beauty of Healthier Together, and the roles that you all have in your anchor institutions, be that the anchor institution hospital secondary care setting or the sort of hyper local in the community anchor of primary care, the beauty is that you have a huge power to convene and to bring people together in a real concrete way. I thought that Alison Morton from the Institute of Health Visiting had a far more impressive slide when she pulled up the problems, obviously, that young people are or patients are facing when they have all of the different agencies that they're working with. But if, again, we just start to flip things on their head, young people, team around the child model, the young person is often surrounded by a whole bunch of strangers, of adults, of people that are asking the same questions. If we just flip it on its head and work out where the young person, who is it that the young person already has trust and rapport with, then how about we flip it on its head and talk about the team around the key worker and support them. Now, David James
so John,
has developed.
Good news. Dave has actually joined the meeting. So I might call Dave in actually at this point.
Yeah, at this perfect timing.
Great. Okay, Dave, over to you.
Hello, Sanjay. I'm not in prison, as this backdrop would appear, and I hope the background noise isn't too deafening. I'm up the stairs in the Aegeus Bowl at the Wessex PCCN conference, and I've found the only place that's not surrounded by people talking very loudly. Thank you for the opportunity to speak. It's amazing to see so many people here for a Healthier Together conference. I guess I come at this with two roles. I am the acute care lead for Healthier Together in its Wessex iteration and share the core content group, so I know quite a few of you from that. But actually, the reason I'm talking today is particularly to promote something called the HEEADSSS App, and to kind of offer it out there to those of you in your various ICBs and to flag it up as something that's something that you could get involved with and we could talk about more. So what I'm going to do, I'm just going to maximize this so I can screen share. With me 1 second. I'm hoping I have permission to do that. If not, I'm sure Holly can give that to me. Hang on 1 sec. So hopefully in front of you now should be a kind of turquoise screen.
Yeah, we can see that, Dave. Thank you.
Excellent. And so, so head screening, I'm sure a lot of you will have heard of it, but essentially it is a tool used for psychosocial screening in young people. And it seeks to help a young person describe the issues in their life using a set of standardized domains, and allows a professional to signpost them to resources that might be able to help within those domains. So really it's looking for psychosocial risk factors and sort of direct things that might prevent harm down the line. Originally sort of started in the 1990s as a transitional care tool. So people with chronic conditions going to clinic will be asked these questions repeatedly. And I guess over the last 10 years now, there's been a real sort of appetite to think, how can we use the front door of hospitals, but not only that, GP surgeries, you know, adolescent drop-in clinics, all sorts of places, that wherever a young person meets health, or potentially even education or youth work, that it's kind of screened that takes place. And, you know, I guess people now talk about social prescribing, but really from the beginning, it was about signposting. So about 6 years ago in Wessex, we developed an app for head screening that would allow a professional and now also a young person or a parent to lead a young person through the domains, and I'll go through what they are in a second, to look for risk factors within each of those domains and to offer help. And of course, with any screening, it's not enough to just ask questions. What you want to be doing is asking questions with a purpose that you will then follow that up with an answer or with a resource that you can offer. And so what the app does is, rather than just asking questions in those 8 domains, is to link it with local resources. And so the Heads app is free to access for anyone. It's free to register. I'm in the professionals page, but all you do, you can see that web address in the top left-hand corner, app.heads.uk. It also is free to download from App Store or from Google Play. When you register initially, it will ask you where you work. And at the moment, it's only mapped to resources in Wessex. We've just agreed with Northern Ireland that Northern Ireland are going to have their own region, and we've entered an agreement with them, you know, that for a relatively modest cost, he says, getting a salesman pitch on, that they can build their own section within there. But certainly there are national resources. So even if you haven't got your local resources on there, it has a purpose. When you open it, it tells you initially how to do a head screen and what a head screen is. And then I will just go on to show you the domains that it includes. So these are the domains of a head screen. So home, education and employment, eating, activities, drugs, alcohol and smoking, sex, suicide and mood, and safety. And the safety is really around sort of violence prevention, criminality prevention, that kind of stuff. So sort of safe at home, safe at school, safe in your local community. We have now also have a young person self-screen. So young people can also use this on tablets, on iPads, on phones, and they can go through a list of questions themselves, which allow them to then be self-signposted to resources that might help. So to show you what I'm talking about, so this is the home domain. And so within the home domain, there are some suggested questions. Now, when head screening was first kind of thought of as a concept by some American pediatricians, they focused on the domains much more than the questions. And so these questions are questions that we think are sensible, questions to ask within in that domain, but they're not mandatory questions. But you know, things like, you know, who do you live with? Who would you speak to if you were sad? You know, what's it like at home, to really sort of build that rapport. And then the questions that kind of help you know, do I need to signpost, which would be things like, are you a young carer? Are there financial worries? Are you homeless? Are you a homeless young person? Does your family suffer from, you know, that kind of stuff? Are you unsafe where you are? And if you find an issue, you click yes, you click view resources. And what then that allows you to do is see regional resources. So this knows I work in Southampton. And so this is showing me resources that are specific to Southampton that I can then, in a good old healthier together style, send to them via text message or email. I can also view national resources and send those as well. And so this is allowing a kind of real-time, opportunistic screen to find an issue with a young person and send them resources to them that might be directly helpful. Now, what this doesn't do, and you know, I often, when I have conversations with regions, because I must have probably discussed this now with 5 or 6 regions around the country who think it's a great idea, but they never quite get any money together to sort of take it forward. But one of the questions I often get asked is, well, can I make this link into kind of case notes? Can I, because I'd like to record this formally in the health record. No, because the app has been built on quite a tight budget, that this actually, everything holds within it. It doesn't contain data. A fair few of you will probably know GDPR and other data regulations mean that collecting any kind of data about under 18s is a complete minefield, and is often just best avoided. So we don't store anything on here. But of course, if you are doing this as part of a health encounter, what you can do is just write in your notes, head screen performed using app, identified issue around, you know, young care, or around you know, drug use, signposted to, you know, and then name your resource, and that kind of covers that off. Obviously, when dealing with young people under the age of 18, safeguarding issues may come up. This app does not take away our responsibility to, if it's not just a normal adolescent sort of low risk psychosocial risk factor. If this is actually I'm in a relationship with a 40-year-old and I've been groomed, or actually I haven't been to school for 9 months because I'm addicted to X, Y, or Z drug. Signposting is not adequate for that, but this is really trying to find those things that you wouldn't otherwise know about as part of your consultation, and offer that kind of first tier of support in order to try and prevent things from becoming an issue down the line. And so if there are regions out there, obviously, Sanjay always tells me off because I lose track of the number of ICBs that we've now got Healthier Together in. But the HEADSSS app is a kind of natural partner for those regions that have already taken Healthier Together on. We fund it through the same part of our finances, so it's very easy if you already have a financial agreement with us and money has already sort of changed hands, that actually we can kind of bolt this on relatively easily, create regions, and talk people through how to upload things to the CMS. I'm almost as good at selling stuff as Sanjay is. I will never ever quite possess the supreme skill that he does, but yeah, that is me done, and I'm very up for any questions you might have.
Dave, you're quite right. It's the Indian in me that makes me a great salesperson, but you make an excellent sort of second at selling stuff. So no, a brilliant resource. And I think between you and John together, John articulating how making every contact count within acute settings with young people is challenging for clinicians, because often we don't know what the local services are. We don't kind of quite get, as Emma and Nicole and Holly described, our preconceptions about young people are so different to what, when we make the time to talk to them, what they actually want. And so I think anything that can signpost young people when so a question for you, Dave, and I know we've got very little time. We've got about 5 minutes of questions, and everyone's desperate for lunch, especially me. And we've only got half hour till the next session starts after that. So, Dave, in terms of clinicians signposting young people to the HEADSSS app, what can they just use it themselves? Do we know if young people themselves could just use that content and kind of take out the middleman?
Yeah, absolutely. And we had a fabulous student project this time last year, this time 2 years ago. I lose track of time, where we actually did go all the way back to, and it may allow me to do this. Yeah, so you can see here when you open the very initial version that am I still screen sharing? Yes.
Yes, you are.
That there is a young person option on there. And so actually the young person can do this whilst they are waiting in the waiting room. If you advertise it on posters in there, or you sort of signpost it through your initial kind of assessment, whether that's triage or streaming or whatever, or in your waiting room in your GP surgery. Now, I would suggest that the true value of this app is in having local resources linked to it. And so I think whilst you can say that, when you get down here and you say your region, you can certainly say area not listed, and those will only get the national resources. So there is still some value in that. You'll still get Barnardo's and Childline and all these kind of fabulous national resources. But I think that the true value in this is in a young person in Sheffield, going on here and saying, where is my local drug and alcohol service, and it will tell me.
So I'm sure that's the question many people who have listened to you will be asking is, God, that's a massive piece of work, the local service bit. How have you managed it with the HEADSSS app for Hampshire and the Isle of Wight or Essex? How do you keep them up to date, and how do you populate them in the first place?
So I think, brilliant question. The initial one, often you will find that there are offices within your local authorities that have fabulous lists already on there that you just populate. And it's amazing what, some Googling and talking to youth workers who work in your patch, and just almost blocking the day out of your diary just to sit there and get it all up there. The process on the website of uploading it is simple. Once you've got a list, it takes about 90 seconds per resource tops to upload on there. I think that the really tricky thing with this is what you described, which is keeping it up to date, because actually this kind of thing dies as soon as links don't work. And that's why I think the reason it hasn't always worked for local regions is that I'm very keen that any local region has a local administrator. It only needs to be, a few hours a month, but who randomly goes on there from time to time to say, does that provider still exist? Because as we know, in this sphere, funding cycles are short. people have to recommission for services, names of charities change, web addresses change. And so but I think one of the good things with aligning it to Healthier Together is often actually there is some of that admin there already, and you can bolt this on to someone that's already keeping a website up to date, that they keep this update as well.